September is Gynecologic and Ovarian Cancer Awareness Month, and we've got a doctor making a house call. The Health Source podcast starts right now.
You are listening to the Health Source podcast, presented by the Marshall Health Network. Now here's your host, Rick
Hello
Lloyd.
again, everybody, and welcome into the Health Source podcast brought to you by the Marshall Health Network. We are on the campus of Marshall University today talking about a very serious issue. More than 100,000 women in the U.S. every year are diagnosed with a gynecologic cancer. And we have probably one of the most esteemed experts in the house today to talk about this, Dr. Nadim Bou Zgheib. Thank you so much for your time today, sir. He is the chief of the Gynecologic Oncology Department for the Marshall Health Network. And first off, let's address the elephant in the room. We probably have a number of women watching and listening to this podcast thinking, okay, two guys up there talking about gynecologic cancers. But let me assure you, this is a renowned expert, arguably knows more about it than anyone in the region. I, on the other hand, absolutely clueless. This is not my lane, but that's good because that means I'll ask a lot of questions. And maybe we can get some of your questions answered today. So first of all, doctor, thank you for joining us. We appreciate your time today. Just talk a little bit about the different types of gynecologic cancers and what you come up across mostly.
Well, first of all, thank you, Rick, for having me. It's a very important opportunity to come out and then talk about this very important topic that's near and dear to my heart. To talk about GYN cancers in general. Yes, we're men, but we have mothers, sisters, daughters, and then it's a very important topic it affects everybody. You're absolutely right. Unfortunately, we still deal with a high number of GYN malignancies in the United States, and from ovarian cancer, which is and was considered the deadliest disease, GYN malignancy disease, to endometrial cancer that's actually making, unfortunately, more and more of a strides and then becoming more and more prominent and deadly, unfortunately. And then also cervix cancer, even though it's one of those most preventable type of disease with what we will be talking about in a minute. But then, unfortunately, we still see a fair amount of cervical cancer patients and then vulvar cancers, vaginal cancers, and some rare conditions such as pregnancy-related malignancies, such as gestational trophoblastic disease. But unfortunately, this type of malignancy can affect women of all different ages. It can happen for young girls, and then unfortunately all the way up to older ladies as well.
A lot to get into. You mentioned the cervical cancer. Let's start there because a lot of people watching might also have teenage daughters, and a big issue is the HPV vaccine. Your stance on that and where it fits into what you do. Absolutely.
So cervix cancer is one of the kind of most preventable type of GYN malignancies based on the fact that we have a good vaccine that covers a lot of subtypes of the virus. So HPV is a virus that is known to be linked to cervix cancer at a high percentage, with the most common type of cervix cancer, because there are more than one type of cervix cancer, but the most common type is totally almost 99% linked to the HPV virus. And then with that, it is covered or is protected primarily by the vaccine. It does cover for 9 subtypes of the virus that can actually reduce the risk of developing the most common type of cervix cancer. Let alone the vaccine as well is important, but also the prevention and the screening for it by the pap smears and then a regular follow-up to the gynecologist is recommended. Starting, at a young age and we recommend to start pap smear at the age of 21 and moving forward with the recommendation of the gynecologist. And a once-a-year visit with a gynecologist, despite whether or not having a pap smear will be recommended.
Now, other than routine screenings, which obviously go a long way in catching anything early, what are some of the other things that can be done to make sure that it's not like when you have a cyst on your ovary, there's no real symptoms. It can just happen. So other than just routine screenings, what are some things that people can do to make sure that they're completely healthy?
Unfortunately, there are some things that kind of relates to the general well-being of the lady, and then there are some things that are related more to the GYN well-being. As far as the general well-being, we recommend obviously healthy habits when it comes down to diet and exercise, and then obviously relieving stress and all that, those are definitely recommended in general. Now, when it comes down to the GYN health, it is recommended, as you said, to kind of follow up the screening. Smoking is a big thing when it comes down to GYN health and general health in general. Avoiding smoking, including vaping as well, would be an absolute improvement in the GYN health, or an actual benefit for the GYN health in general. And obviously, as we said, making sure that someone, if developing symptoms, not to kind of brush it away, but just actually consult with a GYN, with a gynecologist, to actually make sure that they're doing the right thing.
And there obviously is a genetic component to this as well. Do you have different recommendations for people based on their family history?
Now, in general, patients with family history of GYN malignancy in general should be kind of considered to be carrier of a higher risk of developing such a malignancy, regardless of their genetic makeover. Now, should they have tested themselves and then developed, or have been tested and found to be positive for certain genetic mutations, such as BRCA mutations or others, those are considered to be carrier for a much higher risk of developing different GYN malignancies, such as ovarian malignancy or fallopian tube cancer, and would require some different type of a screening than the general population. So in that situation, definitely the earlier that we can start the discussion, the screening, and the protocol for these patients, the more conservative approach and then more kind of lifestyle modification that we can introduce to kind of minimize the risk and then have the best outcome for them on the long run.
You mentioned BRCA BRCA. How do you work with genetic counselors to bring them in to kind of talk about genetic syndromes?
Absolutely. So we're lucky to have a genetic team, part of our cancer center at Marshall and at the Edwards Cancer Center and in the network in general. So, but in general, the counselors will be the one to actually go through the genetic testing, go through the counseling about what it means to carry that mutation and whatnot, because one genetic mutation could have more than one repercussion. Right. Could have one GYN repercussion, but also could have other system that could be involved. And then that role of the counselor will be kind of a navigator for that patient to kind of go in and seek that subspecialty type of attention in order to improve her health in general. But yeah, we do work closely with them on a regular basis to pretty much either treat, get involved with the counseling, or obviously do like what we call a prophylactic surgery or risk-reducing surgery in some very, very defined situations as well.
What are some of the common misconceptions that you've seen when it comes to ovarian and gynecologic cancers?
So unfortunately, Rick, the ovarian cancer in particular is a silent killer. So unfortunately, because what you've mentioned earlier, that there is really sometimes no specific sign or symptom associated with ovarian cancer. It is important to have kind of a self-awareness of someone's body and then also report whether or not someone is having regular symptoms for 2 weeks out of the year of having some GI discomfort, some sort of a belly, discomfort, bloating, sometimes some nausea, sometimes a little bit of a discomfort, feeling a little bit of an increased abdominal girth. That those patients should actually seek medical attention. Because, it could be related to an indigestion, or it could be related to a GI, gastritis or a colitis or something. But that's also could be considered as a misconception because it could hide a GYN, unfortunately, GYN malignancy. And until you actually get the full evaluation for that patient, the patient could, unfortunately, be developing an ovarian cancer. And then most of the times, unfortunately, we catch them a little too late.
Now, how important is it to you to build trust with these patients? I mean, you're not dealing with a broken hand or a cold. I mean, this is some serious stuff here, for lack of a better way to put it. And it takes an emotional toll on obviously the patient and their family, but also the doctors as well. You're a human being. What are the challenges that you face in dealing with that type of situation with these patients?
One of the things, Rick, that attracted me to GYN oncology as a special or subspecialty is that relationship that you just mentioned, that deep patient-physician relationship that actually is the pillar that you build any type of a treatment on it. Without that trust, that confidence, that partnership that you would kind of engage yourself and the patient with, we can't get to any kind of positive or good outcome. But it's definitely something that we rely on. And it is most of the times required on a long path of the journey of the patient through her diagnosis, evaluation, and of course her treatment process. Sometimes the treatment could be complex. It's not like a one-stop shop type of thing situation. So that complexity of the treatment requires, as we said, the partnership and the availability and the trust that the patient can rely on us or my team to actually lean on to answering some questions or treating some side effects or get to a point where she's actually able to have a better quality of life, not so much just improving of her outcome in general. So quality of life is also something that we focus on. So yes, with that long process, yes, it is challenging. It's definitely challenging because, with the challenges of the disease comes the challenging of the humanity behind it as well. So it's affecting the humanity in all different sorts of shape because she's going to miss someone's birthday because she's, undergoing certain disease treatment, or she's going to miss someone's graduation because, again, she's recovering from such a surgery. So it does affect us as well because we try our best to kind of not to forget that we're actually treating a patient rather than actually treating a disease. So it is important that, we kind of look at the patient in the wholesome, in the totality, and then try to get her to be the best person that she could be, quality speaking, and still enjoy her quality of life, still enjoy her life while undergoing the right medical treatment and the right recommendation for her treatment.
So many important points that you brought up in that. Obviously, as a doctor, it's your job to tell them like it is. This is how it is. But you can do that with compassion as well. And the mind can play a role. I mean, the mind can't kill cancer cells, but a positive outlook can help you navigate that journey. How do you balance like aggressive treatment approaches with, as you mentioned, the quality of life? That seems to almost be a juxtaposition there. How do you balance that when you're talking to these people?
Excellent question, Rick. So obviously, the more aggressive, or let me say, like the harder the treatment is, meaning it could be hard not so much with the type of treatment, but harder as far as like the chances of it actually working. So the more challenging thing is when you're actually recommending a treatment because and not knowing exactly the chances of the chance of response from such a treatment. Yeah. For example, a disease being too advanced, or the patient has failed several lines of treatment, and we're getting to a point where the treatment options are becoming more and more limited. So that begs the question again that it is important to catch the disease early on, sure, and then that would simplify the treatment a whole lot, and then hopefully get the cure for a lot of percentage of the cases. But going back to the question, the harder the relationship with the patient treatment is, or the harder the journey is, the more important would be to kind of focus on the quality of life in this situation. Yeah. Because that's when the actual quality of life matters. Because not that it doesn't matter at the earlier on, onset of disease or the treatment or initial phases of the treatment, but you would allow yourself for a little bit more kind of aggressive treatment to actually get to the cure, right, initial on, rather than just focusing on the quality of life. And then yes, you have to be direct, you have to be kind of upfront, and then just pretty much train the patient, push the patient to kind of be as upfront and as positive as possible to fight that disease mentally, emotionally, sure, and then also physically. And then on the other hand, medically speaking, we have to kind of mirror that type of approach. We have to be kind of all hands on deck to pretty much try to get the best outcome, and then hopefully, obviously aiming for a cure in this situation. Unfortunately, sometimes this is not reachable, and that's when we start focusing on the quality of care.
And that's got to be tough because when you get to that finality, and as a doctor, there's really not much else that can be done. The patient still has to go through those stages to get to the point where they'll accept it. And that's taking up time. And so that's a tough balance to be like, yeah, okay, let's try to come to peace with this as quickly as possible so that we can have that quality for whatever is left.
Absolutely, absolutely. And then the good thing is as well, part of the systems and the services that we have at Marshall is we do have that palliative care as service associated with our cancer center that we can obviously rely on them to help the patient and the team navigate through those challenging moments as well.
And I'm glad you brought that up because it's almost an extension of what we were just talking about. How do you integrate palliative care with a survivorship plan?
Absolutely. So again, what we do with patients by looking at the patient journey as a human journey, pretty much, we start focusing more on what the patient needs at a different phases of her journey. Most of the times, obviously, we're aiming for a cure and then not have to kind of dwell and then go through a tough time. But then again, when the disease is proving to us to be so malignant or so aggressive, and then the treatment is failing at a different line of therapy, palliative care becomes very important because not only to treat the disease burden or the symptoms from the disease itself, but also to treat the symptoms from the treatment as well, to help the patient cope and improve her quality of life from her disease treatment as well as her disease burden as well. So to pretty much help her get a little bit more functional, stay more functional, more engaged with her family, more engaged with her life, spend more time at home before we reach to a point where, advanced care is needed at that point.
We talked a little bit about how each treatment is unique and each specific person's journey is unique. The beginning of it is unique as well. Have you found any disparities that can lead to different outcomes, whether it be social, economic, psychological? I mean, do different disparities lead to different outcomes?
Definitely, there are a lot of papers right now looking at disparities in healthcare in general, but also in GYN or women's health in particular. Racial disparity played a role with African American, unfortunately, kind of having more of a disease burden when it comes down to like endometrial cancer or different type of GYN malignancies, and or unfortunately worse outcome and worse prognosis. But when it comes down to if we want to keep it general here, Rick, the support, the family support, I believe, it plays a big role in patients' outcome. Patients that have the family support that would help her navigate at home, be an extension of the medical team, of the nursing team, of the supportive team at the hospital, be an extension of them at home, does play a big role in keeping the patient healthy enough to undergo the journey of the treatment in general, and particularly when it comes down to surgery or chemotherapy or radiation or all of the above.
Yeah.
Now, definitely having also that the disparity also plays a role in diagnosing cancer. Obviously, we mentioned about early detection and early screening and early diagnosis, but unfortunately, we do see that socioeconomical status can play a role. And if patients and or family are focusing on making end meets or paying the bills and stuff, they're probably not focusing on screening.
Or not insured.
Yes, sir. Trying to kind of undergo a screening or following up on medical care kind of falls behind, and unfortunately, that sometimes could be associated with a much more advanced stage of presentation for her cancer and a much more difficult disease outcome.
Now, cancer historically has been one of the biggest killers of Americans, and it's a field that's always adapting and trying to search for that cure. Do you see immunotherapy and targeted therapies evolving?
Absolutely, Rick. I mean, that's kind of it's been immunotherapy. It's not new. It's been there. It's been studied for years, I would say. But lately, mainly in GYN malignancy, it started becoming more of a mainstay treatment that actually changed or moved the needle when it comes down to overall prognosis, when it comes down to overall survival from different tough disease situations. I'll give you an example. Before, when someone would come in with, unfortunately, a metastatic cervix cancer, she would have less than a year to live. But right now we're looking at, with the new advances, with the new medications, with the immunotherapy, we're talking about many years of her median overall survival. So that really changed how we're treating and how the patients are looking at their disease and then trying to kind of get to live longer, but also live healthier as well.
So specifically, are there any recent advancements that do have you excited?
Definitely. Any type of disease treatment that would actually improve overall survival. When it comes down, we've mentioned immunotherapy. There are a lot of targeted therapy. Now, in general, in oncology, we're not treating based on disease site. For example, you could have a disease in the lungs, but it's treated by a certain medication that could work based on the molecular profiling of that disease on any other tissue of origin that's got the similar molecular profile. So targeted therapy is becoming more and more the way to go. We're not treating just based on, this is, breast cancer, this is treatment just for breast cancer or just for lung cancer or just for ovarian cancer. But a lot of that's what opened up the door for all the oncological treatments to actually mismatch or mix and match or try to pretty much get the right treatment with the right target by having the advanced technology. And then AI is going to help us even more further kind of pushing and repurposing these drugs to actually get the right treatment for the right patient because of the right molecular profiling, because of the right signature that's associated with our treatment.
Now, when you say gynecologic and ovarian cancer, it sounds so specific, but it really covers a wide variety, a full spectrum of ailments and treatments. And with that in mind, it's important to put together a good team. Just talk a little bit about the work that you do with others in the Marshall healthcare system and how it does become comprehensive care.
Absolutely. So we're part of we're at the cancer center, at the Edwards Cancer Center, and then we do have a team. Part of my team, we've got nurse practitioners or advanced care providers, and nurses, MAs. We also have residents and fellows and medical students kind of rotating with us. All of us kind of pretty much caring for that patient. We collaborate quite a bit with the surgical oncology divisions of the cancer center, obviously the medical oncology division and the infusion center and the radiation oncology. And then it becomes more important when you're actually trying to build a treatment planning for a patient that would require that complex care, that would require radiation or require chemo or require surgery or all of them at the same time or at different times. That's when we actually collaborate also with radiology, radiation oncology, intervention radiology. So luckily, we're in a situation where we've got all of these services available to us to try to build the best care for the patients and deliver the best outcome for them.
We'll get you out of here on this. I know we went over a lot of this earlier in various bits and pieces, but maybe succinctly, if you had any advice for someone on the best way that they can take care of themselves and to stay healthy and to not let this affect them, especially if maybe they're at high risk, what advice would you give them?
Definitely eat healthy. That would be number one. Exercise daily. Make it part of your routine. Get your screening. Try to make time to actually visit the doctor once a year and then your gynecologist once a year. It's very important to catch any problems that can happen before it becomes of a major problem, and then get it treated and be done with it.
I mean, it sounds simple, but that's the key, right? Early detection is the key in all of this.
Sir. Yes, sir.
All right, Dr. Nadim Bou Zgheib, thank you so much for your time today. We appreciate it. He's the expert. He knows.
Thank you, Rick.
And I hope I did my part in being so ignorant on this and asking questions that were relevant to everyone listening and watching. And remember, if you're listening on Spotify, make sure to like and subscribe so you'll know when the next episode drops. Again, we're here for you, trying to help you on your path to wellness. We can't do this without the support of the Marshall Health System as well, so thanks to them as well. So we'll talk about something just as important next time, hopefully. But this was really insightful stuff. Thank you, Doctor.
Thank you.
And until next time, I'm Rick Lord. Take care.
That was the Health Source Podcast, presented by the Marshall Health Network.